we can start by الكتاب. Then let us plan this session. As we planned before, we have two groups, okay, for two long cases. Okay, there will be one role player, one of you. The previous groups, they have a very good role player because they may need you, inshallah, in the master and postgrad exam after that. But it also gives you the impression how negotiation between the doctor and the family must be. The other one, be one of you. We are going to assessment him also for how he is getting history, and he can discuss with me. It is the same like long case. Okay, he will take only about 20 minutes for collection of the knowledge or the history. I prefer to be between 10 to 15 as we can. Okay, so you must be a bit hurry, and this is the scenario also during the final exam for long case. You need 1 hour only to finish everything. Okay, the third one will give us the differential diagnosis, and the fourth one is going to give us a good OSCE for the clinical signs which we can see by our eyes. Let us start, inshallah, and I feel that you will be gaining a good, inshallah, clinical sense from that session. And always remember that your value is in your clinical ability. As a doctor, number one, number two, number three is your clinical ability. Is your ability to have a good flow, how to examine the patient. It may be, inshallah, at the end of the session, if we have some time, I can give you just a few minutes how to handle the flow of examination. So let us say Bismillah and start by the first group. You need at the end to write for me group 1, blah, 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 number 1, number 2, number 3, so I can give you marking, inshallah, at the end. Even for the role player. Okay? Say Bismillah. Sorry, during the presentation, the only one is opening the microphone is the one speaking. All others try to switch off, please, the microphone, so no interruption from our home atmosphere for anyone. Okay.
Bismillahirrahmanirrahim. So I'm Adeline Afika from Group 2. I'm going to be the first actor as a mother's patient.
Okay. So we have one more to assign the timing, about 10 to 15 minutes, 10 to 15 minutes, and 10 to 15 minutes, inshallah, at the end. Okay? Okay, so who else is you now?
Assalamualaikum. I'll be the one talking.
Okay, that's fine. Go ahead.
Okay, Assalamualaikum. I am Ifa, a medical student here. Can I ask a few questions about your son?
Yes, sure.
What is the name of your baby?
You can call me Suraya.
Your baby?
My baby's Rizky.
Okay. How old is he?
He's 2 months old.
Why did you bring him here?
Oh, I first noticed his breathing stopped while lying on my lap. So I was panicked at that time, so I bring him right away.
No. When did the bleeding stop?
I'm not sure, doctor, but 4 days ago, I noticed he developed runny nose and followed by fever, just a mild fever, and his breathing a little bit noisy.
Mm-hmm. So, is it, did you mention that he has cough?
Oh yeah, he also developed cough during that time.
Oh, okay. Is there any fever?
Fever, yeah, but just a mild type.
Did you take the temperature at home?
Um, I remember it was 37.4.
Oh, okay. Um, okay, for the cough, have you noticed that, is there any symptoms?
Any symptoms like
Symptoms.
hospital? No, no, no.
No. Okay. Aside from the noisy breathing, did he have any shortness of breath?
No.
Did he take the breast milk as usual?
Oh yeah, I noticed he a little bit less interest to breastfeed, and he looked a little bit irritable.
Okay. So, during the breathlessness episodes, did you notice the skin becomes bluish?
Oh yeah.
And is it the chest becomes indrawn?
That I'm not sure, doctor.
To notice that. So, aside from him, is there any other sick person at home?
Yeah. His sister got fever
Oh,
few days
okay.
back.
The same symptom.
Yeah, the same symptom.
Uh, 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 did you send him to a daycare or some? Why?
Sorry, pardon?
Did you send him to a daycare?
Yes,
I,
because I'm working.
I see. What are you looking at?
Pardon?
What are you looking at?
Oh, I'm a lecturer.
Mhm. Um, what is your husband's occupation?
Oh, he's also a lecturer.
Mm, did he smoke or anybody in the room smoke?
Oh no no.
Do you guys have any pets at home?
No.
Uh, for your baby, is there any known allergy?
Mm, I don't think so. No.
Prior to the episode, have you noticed is there anything happened like trauma to the chest or did he experience any foreign body?
Not really. No.
Just to make sure, is he exposed to anyone with COVID-19?
No.
Um, okay, I want to ask, either, either you or your husband, do you guys have any history of bronchial asthma or rhinitis or eczema?
I have none of those diseases, but my husband do. He has bronchial asthma since
Or
child.
that persistent until now?
Pardon?
Is The asthma persisted until now?
Sometimes.
Oh, okay. Have you got any other child other than this?
Yes. His sister, 2 years
Oh,
old.
okay. Does the sister have asthma too?
No.
Hmm. Is there any history of like Down syndrome or autoimmune disease or respiratory problem in your family?
No.
Hmm. So, um, you said you both are lecturers, right? And both are non-smokers. So, where did you live?
Oh, I live nearby at Kotesas.
I see. Okay. Okay, coming back to your baby. Okay, you said that he has fever and loss of appetite, right?
Oh, no.
Is there any other problem?
Mm,
Did he lost his breath during sleep?
no. But he has. Sometimes I can hear him snoring during sleep.
Oh, okay. Is there any diarrhea or episode of vomiting?
No.
No. Is there any the sound of the cough? Is it whooping or barking?
No whooping or barking.
Did you notice any changes of his sound, like hoarse, like during the crying? Is there any hoarse voice?
Oh, no. I just hear wheezing, kind of wheezing.
Okay. Mm, did you notice during the cough, is there any blood coming from the nose or the mouth?
No.
Any night sweat?
That's what, no. Is he going to be okay, doctor?
Huh?
Is my baby going to be okay?
Okay, don't worry. We have give him the nebulizer, so he will be okay.
Trust me.
Okay. Okay. For his birth history, is there any problem during your pregnancy?
Alhamdulillah, no. It went well.
So is he born full term?
Oh, he's quite earlier, like at 36 week.
Did you get C-sec or this vaginal delivery?
What? Pardon?
Is it through vaginal delivery or C-sec?
Oh, normal delivery.
What is his birth weight?
Oh, what? What?
Birth weight.
Birth weight around 3.4.
Um, do you have any complication during and after delivery?
No.
Did he get jaundice?
Jaundice, yeah. It lasts for about 2 to 3 days, like that.
No, hospital admission.
No.
For now, he is just 2 months old. So, are you breastfeeding him?
Yes.
So you said you are working. So how did you give the milk then?
Oh, I used to pump. I store the milk.
Mm-hmm.
Okay.
Mm-hmm.
And I give it to the caretaker lah, at the nursery.
So did the caretaker give him how frequent does the caretaker give him milk? Like how many hours leave?
Usually every 2 hours, like that.
Mm-hmm. How many meals per day?
Around. So this the container is around 3 ounce. So 3 ounce per
Yes.
4 to 2 hours.
So, as for his development, can he hold his head by himself now?
Pardon?
Can he hold his head up by himself?
No. Yes.
If you are playing with him, can he like spot the object?
Yeah.
When you talk to him, did he like look to your voice, look for your voice?
Yeah, I noticed that.
Can he smile already?
Yeah.
So, he said he was never hospitalized, right? Do you have any other disease that been diagnosed before?
Alhamdulillah, no disease.
Did you put him on any medication or supplement?
No.
So, did you get him for the vaccine according to the schedule?
Yes, I just follow the schedule.
For his age, he should get 3 times vaccine follow up until now, right?
Yeah.
You attended all according to the schedule.
Yes, of course.
Good. You're a very good mother. Okay. I think we finished with the classes.
Doctor?
Okay, I'll just proceed with the physical examination then. So, okay, this physical examination was done in ED during the episode of breathlessness. Okay. So, on general examination, the child was conscious but less active. He was in respiratory distress. He has a proper body build with good nutritional status. There was no dysmorphic features, rashes, or abnormal movement noted. On peripheral examination, there was peripheral phimosis but no clubbing or palmar erythema. BCG scar was noted on his left deltoid muscle. On examination of the head and neck, the head size and shape was normal. There was no head swelling, head injury, conjunctival failure, or scleral jaundice. Both ears revealed earwax with no sign of infection or ear discharge. The tongue was moist, tonsils were not inflamed with no exudate, and there was no central sinus. There was no abnormal swelling, cervical lymphadenopathy, or abnormal palpation noted on the neck. For vital signs, the blood pressure was 87/42, which is bradycardia. Heart rate was 132, regular rhythm and good volume. Respiratory rate was 60 breaths per minute, which is tachycardic. And he was at febrile with temperature 57.8 degrees Celsius. And SpO2 is just 90 under the room air. Okay. And then for the respiratory examination, the patient was on inspection. The patient was in respiratory distress. He was tachypneic, sinus, using accessory muscle to breathe, having nasal flare, and wheezing was heard. There was moderate chest recession. No surgical scar or dilated veins was noted. On palpation, trachea was centrally located. However, there were reduced chest expansion and diminished tactile vocal parameters. Okay, on percussion, lungs are hyperresonant on both sides and liver displaced downwards. On auscultation, there is prolonged expiration and mild vibrational crepitations were noted. These systems are remarkable. So, to conclude, this patient, Muhammad Rizki, a 2-month-old boy, was admitted here just now in view of breathlessness and dry cough for 3 days duration. He also had nasal discharge, fever, noisy breathing, shortness of breath, snoring while asleep, become less active and refused oral intake, and he became cyanotic on the day of admission. He had contact with his sister with URTI symptoms. Otherwise, there was no body weakness, whooping or barking cough, hemoptysis, or aspiration of foreign body, or exposure to allergen or person with COVID-19. So on physical examination, patient was in respiratory distress. There is moderate chest recession and the lungs are hyperinflated. And there was also mild vibratory palpitation rate. So, yeah, that's the key. If you can speak about this too. What is the diagnosis?
So, what is your diagnosis?
My functional diagnosis is viral bronchiolitis.
Viral bronchiolitis. How can you confirm that?
Because the characteristic of the cough itself, it is dry, and then it is preceded with coryzal symptoms, which is the nasal discharge. And besides that, he has fever and breathing difficulty, noisy breathing, and also during the day of admission, he become active and cyanotic. And there was no history of atopy for him.
So how can you confirm it is bronchiolitis? You have now clinical suspicious. So what investigations did you need to consider now?
I would like to do chest X-ray.
Sorry?
I would like to do chest X-ray to confirm the hyperinflation.
Okay.
And then other than that, this is for viral bronchiolitis, it is usually physically diagnosed.
Now you requested for chest X-ray. Looking for what?
Oh, chest X-ray, I will look for the descent of the diaphragm, the hyperinflation.
If you are going to do to request any investigation, you must know what is the goal from that and what we are looking for. So you either need to diagnose bronchiolitis or rule out others.
Oh, yeah.
So bronchiolitis, Abdullah Arif, what you will see with bronchiolitis, you are now you have two copies, one mirror shape and one. What is the for bronchiolitis? How can we diagnose it? By chest X-ray.
Can you hear me, Doctor?
Yes, very clear.
I would like to find any consolidation, any haziness.
It means bronchiolitis.
So for bronchiolitis in chest X-ray, I would like to see any heaviness of the lung.
Any?
Sorry,
Any what?
any heaviness or consolidation in the lung.
So can answer what is the gold standard for bronchiolitis X-ray?
I think we should also check for hyperinflation in lung.
Yes, this is established one, hyper inflation. But sometimes, as Arif said, you can find sometimes it changes, looks like pneumonia, some consolidation in severe one. That's why in many cases, if it is severe, you need to do some investigation. So what other investigation, if do you need to do?
So for other investigation,
Let us make it more straightforward. So what is the cause? What is the cause of bronchiolitis?
viral infection,
Of course, which virus?
RSV virus is the common cause.
Okay, how can we diagnose or how can we investigate this RSV virus?
For using their blood investigation.
Sorry?
Blood investigation.
Very difficult. There is something easy. Who can answer? We have just simple nasal swab for RSV. It is the same which you are diagnosing COVID by nasopharyngeal and the mouth. Here, nasopharyngeal swab for RSV is available and very simple and can give you a rapid diagnosis. In spite, sometimes there may be secondary bacterial infection also. Okay. If you did blood investigation, usually what blood investigation you are going to request?
For blood count.
Why? Looking for what?
For blood count, you see the white blood cell increase, and also neutropenia.
Which type of white cell?
Neutropenia.
Now you have WBC 30 or 29. The total.
Lymphocytosis and neutropenia.
Sorry?
Lymphocytosis and neutropenia.
Neutrophil 4. What type of infection will find the neutrophils are increased?
Sorry, doctor?
If neutrophils are high, what did you suspect the diagnosis will be?
There is bacterial infection.
Bacterial. So it is a viral.
So viral lymphocytosis.
Okay, how can we rule from the white count? Is it some sort of allergy or not? Allergy. How can we get knowledge from white count?
Oh, allergy.
We look at the eosinophils, doctor.
Yes. How can we know is it typical or atypical microbe? We have atypical microbe for school age, which is mycoplasma, but we have also trichomonas for young children. Okay, so also changes in the monocytes can help us. So that's why I need you to prepare one simple article about how to read the full blood counts, which is the #1 investigation we are requesting. How can we make use of it? You can assign, the group leader can assign 1 or 2 and make it as a one paper, and I need to drop you to my WhatsApp. Okay. So knowledge about RBCs and the possibility of anemia for this age, or anemia of chronic disease, or thalassemia, or like that. Knowledge about the white count and its differential. Knowledge about platelet, even in severe infection, we can get thrombocytopenia, or sometimes we can get reactive thrombocytosis. All this is a knowledge in our hand. If you make your request is full blood count, I mean you will add to it peripheral blood filling. How it can help you? Anyone can answer? It's very important to look for the shape of the cells. It can guide you for anemia or chronic anemia like thalassemia. It can guide you for, even if you suspect malignancy like leukemia, you can see the blast cells. So all this is related to the full blood count we are doing. That's why if you are more professional, you can make use of a simple test in your hand. Otherwise, you can request 100 tests before making the benefit in your hand. Okay. Of course, inflammatory marker can be done like what, Najwa? Inflammatory markers.
Yeah, CRP will increase.
Okay.
Acute.
What else?
ESR?
These are usually in slightly elder children, but most important is that there is test known as procalcitonin. ECT, procalcitonin. Procalcitonin. It is more specific than CRP. It is a bit expensive, but really it is very, very, very important to consider. It helps us to stop the antibiotic, because CRP is not specific for infection. Sometimes it can be increased with other. Okay, that's why she came to a conclusion. Yes, by the age, it is the most common. By the situation, there is another viral infection in the family. Okay, but other important investigation Nagwa must consider is a bedside test. Is there an important bedside investigation to be done?
Yeah. Bedside, just putting on form osmometry and look for the
Okay, very good. But if the baby is severely distressed, we must consider pulse oximetry, which is now considered as one of the vital signs.
Oh, yeah.
We're adding it now to the vital signs. What else?
If he's in respiratory distress, we have to take a clear blood gas to confirm whether it is type 1 or 2.
So for respiratory, for blood gas, it is very important to consider in distressed children or infant like that. Looking for
Hypoxia and
hypoxia, which is what type of respiratory failure presented by hypoxia?
respiratory type 1, hypoxia and hypocapnia, but type 2
No.
hypoxia.
Yes, hypoxia and the normal, not maybe hypo or normal. Yes, type 2 is
Hypercapnia.
hypercapnia. It is very important. Also, we can look for metabolic acidosis, which is the body response to severe, because it may be the patient is going to collapse, has increased lactate in the blood gas itself. Also, if you read now the blood gas in the ICU now, you will find it speaking about lactate. It can give you an important clue for even electrolytes and that. So your easy now is more simple than ours before. But you must be meticulous for that. Okay, do you need to add anything, Nagwa? Okay. Okay, so who will present the differential diagnosis now? Differential diagnosis.
So, my name is Zaki Jamaluddin. So, my differential, firstly, maybe the patient have acute exacerbation of bronchial asthma secondary to viral infection. But, and the points 4 is firstly, the patient have coryzal symptoms, which may act as a trigger for the patient to have acute exacerbation of bronchial asthma. Secondly, the patient have dry cough accompanied by wheezing and nostril breathlessness, and the patient have a sick contact at his daycare, and also have a family history of asthma because of her father. And however, the points against is because of the duration of the symptoms, less probably because it's less than 10 days. And the this is the first episode because previously we didn't have any exacerbation before and no interval symptoms to suggest that this may be an bronchial asthma. And the cough is not associated, it's not worsened by night or not associated with any laughing or crying or physical activity. And however, the points 4 is also the patient also complain of less active. That's for bronchial asthma for the first differential. Should I continue with another, doctor?
What also against it? Is it the age is against?
Yes, the age.
Okay.
The age.
Continue, Zaki.
Okay. Secondly, our differential would be pneumonia. Because I believe pneumonia is quite difficult for us to differentiate in a younger age because of the symptoms is quite similar: fever, patient complains of tachypnea, chest indrawing, sick contact. However, during the investigation, we can differentiate between these two, either is pneumonia or not, or bronchiolitis, given the age.
Other differential diagnosis?
Well, okay. For the third differential diagnosis, it might be COVID-19 infection. The points. Okay. The points.
If all of you didn't mention that, you are in trouble. Okay.
Okay. So for the points for this patient is that this patient has non-productive cough associated with shortness of breath, also low-grade fever, and irritability or poor feeding. However, for the points against is that the patient does not have any apparent close contact with COVID-19 patients, and the patients is not from the red zone, and there was no travel history to any red zones. Yes, that is all for COVID-19.
Any other differential diagnosis?
So another differential diagnosis might be viral induced wheeze. So the points against for viral induced wheeze can be the fever, noisy breathing, and cough, and also shortness of breath. However, the points against is the age of the child, which is 2 months old, and also the recurrency. Usually, viral induced wheeze will have recurrency unless this is the first presentation. So the next differential diagnosis, but the least likely might be the foreign body aspiration. However, for foreign body aspiration, it is usually of rapid onset. So the rapid onset in should the points for foreign body aspiration in this child might be for coughing, but the points against there is no choking, and usually the age itself for this child is 2 months old. Usually the foreign body aspiration is more than 1 year old.
Okay. Good, good. Any more add? Any add more differential diagnosis?
Doctor, can we suggest hypersensitivity reaction? Even though it's less likely, but the patient has coryzal symptoms and also shortness of breath. However, the patient does not have any other signs of hypersensitivity.
Yeah, hyperactivity of the airway, it is some sort of the same like asthma, but with trying to, so I am not so confident. But any other? I will just need to add, because our colleague doesn't touch the prenatal, natal, and the postnatal history. Okay. Mother Afika, they asked you about any detail about antenatal, natal, postnatal?
Yes, she did.
Yeah, antenatal.
Antenatal. Yes.
Yeah. Here in the first 3 months, this is just an important point for you. The late onset sepsis of the neonate sometimes can be extended until 3 months. So if the baby has any signs of infection in the first 3 months, you must come back and ask again about the antenatal. If the mother got any fever, leukocytosis, okay, UTI, high vaginal swab positive, like that. And during birth also, the patient has any problem, because sometimes it can extend until 3 months of age. Okay, so it is very important for that age. I know that it is a bit more detailed, but sometimes you can put neonatal sepsis as one of the differential diagnosis. In a small baby before 3 months, if there is evidence from maternal infection, it can come until late time. If the baby admitted also to the ICU like that and stayed for some times, it can also be healthcare associated infection. Thank you. Now we need to see the OSCE, and I send you one more OSCE to be presented now in your WhatsApp group.
Doctor, can I present the slide?
Yes, please, and add one more slide. I send it to your colleague.
Can you see my screen now?
Yes.
Can you make it full screen?
So for the first OSCE, I would like to invite Brother Badrul.
Okay, Assalamualaikum. So I will present the first part of the OSCE. Farah, can you click on the present button? Okay, so we're gonna show some of the clinical sign picture. So looking at this picture, any one of you could give what the abnormality that you can see from this picture. How about Izati?
The clinical features in this picture, there is chest wall recession.
Yes, it's true. chest wall recession, but can you be more like specific what you can see? What type of recession?
What type of recession?
Yeah, it's okay. So Farah, can you like click? Okay, so what we can see from here is intercostal recession. So we know that recession can be like sternal recession, intercostal, subcostal. Okay, so from this, for the next picture, anyone would like to try?
Subcostal recession.
Yes, correct. Okay, next, Farah. Okay, from this picture, what you can see, Adeline.
Nasoflaring.
Yes. So basically, nasopharynx, we can see like the nose is the circumference of the orifice is like bigger and it's like red. So it's one of the sign of respiratory stress that we need to look out in the patient with respiratory presentation. Okay, so for this picture, Zaki, what you can describe?
We can see bluish discoloration of the lip. We can interpret it as a central cyanosis.
Yeah.
Central cyanosis.
Correct. Next picture.
Not so correct. Come back. Is it, if the lip is bluish, is it central?
Okay.
Oh, it's
peripheral. Lip is still peripheral cyanosis.
Oh,
but
peripheral.
the tongue, you can see also the tongue and the gum can be considered as a central.
Okay. Thank you, Doctor.
Many children, if they are going to swim like that, exposed to cold, you will find their lip slightly.
Buat kat air panas
Zati, your mic is on.
My mic, yes, it's on.
No, no. Our colleague's mic was on just now. He didn't notice. Sorry, Doctor.
So it is very important just to know the hands, the lip, still peripheral, but the tongue and maybe the gum we consider central.
All
Looks
right.
from here that the tongue or the gum looks also blue. Okay. Also for the previous two slides, it's good. I think you need to send it. I will add it to my lecture under upon your name. The most important, you must be a good observer. The first baby is in the incubator. Can you see the first slide? You said this is a baby inside incubator. Usually I will not add this big size baby inside incubator unless he has considerable problem. You see, this is the incubator windows. Next one. This is a baby under nasal swab. As I can see, I don't know, but or a high flow nasal like that. Okay, so this baby needs supplementary support, respiratory support. You must see that. Your eye must working in the field. You must observe anything. So the first one is critical and inside incubator. The second one is critical and giving respiratory support in form of nasal swab. Okay. The third one, he has some nasal flaring, but he's still under his care. But I don't know, is it oxygen supply also or not? This tube. So observation in pediatrics are very good because they cannot tell you anything. And sometimes the mother is working and just come found her baby is sick in the KG or in the Tadika like that. So you must be a good observer to be a good pediatrician. Okay. Continue.
Can you listen to the sound?
No, we can't hear you.
No.
Wait a minute. I just open my mic. You want to play it again, Badrul?
Yes.
From beginning?
Yeah. No. I just like cut the part.
I
It's
see.
just
So
can you listen to it and appreciate? Or it?
Yeah, there's like grunting.
Yes, correct. That is the grunting sound in the baby that we it's one of the sign of the respiratory distress. And also what you can see from uh the chest is that you can see when the baby is breathing, you can see the subcostal recession also. For those who cannot like listen to the sound, you can just Google at the YouTube, it will come out. Okay, next part, Farah.
okay. Next part is this.
Okay, so I'm going to just share with you guys about difference of the difference between bronchiolitis and pneumonia. So this is what I got from the bedside teaching during year 3 with Dr. Asra. So for the bronchiolitis, it's usually the age usually it's less than 2 years old, and it's usually peak at 6 months. And pneumonia, it can be any age. For the fever, as we are aware that the common etiology for bronchiolitis is viral, more common. So we expect that the patient would have low-grade fever. While pneumonia, the commonest cause would be bacteria. So we expect that the fever would be high grade. For the etiology, yes, bronchiolitis viral, more common, which is respiratory syncytial viral, about 70%. For the pneumonia, it's bacteria, but it's different etiology. I mean, different bacteria according to the age of the patient. Like for example, in the school age children, mycoplasma pneumonia infection is like more common. For the breathing sound, so bronchiolitis is more noisy. You can like appreciate from the physical examination, like it will be more wheezy, more noisy. Pneumonia is less noisy because pneumonia is like the infection of the lung parenchyma itself, so it doesn't like it's not usually affecting the airways. So yeah, we do not expect more wheezy sound from pneumonia. And for the secretion, so for the bronchiolitis, we can see like the patient would have more secretion because more uh, chesty cough, chesty chest. Because of the pathophysiology itself, the bronchiolitis is when there is an inflammation at the bronchiole, so the secretion, the mucus secretion will be more and obstruct the airways. But the pneumonia is not really related to the airway. For the antecedent illness, usually bronchiolitis, such as in this patient. So it started with the coryza symptom, right? Like runny nose, cough. So we can say that it's usually preceded with the upper respiratory tract infection, and then it will slowly involve the lower respiratory infection. But pneumonia, usually it will right away with the pneumonia symptom, like SOB. Next, Farah. For the peak phase, usually bronchiolitis, the symptom will peak at the day 4 and also day 5. But the pneumonia, there is no peak phase. It will like continue to worsen until the patient getting the treatment. And for the other physical examinations such as bronchiolitis, we expect commonly they will be presented with bronchi. But pneumonia, they can have bronchi if it involves the airway. If there is a bronchospasm, so they can also be presented with bronchi. So in terms of crepitation, for the bronchiolitis, we expect it's a bilateral involvement. So it's a generalized fine crepitation. But pneumonia, it's usually one lung is more, if it's bilaterally involved, it's usually one lung is more predominant. However, depends on the type of pneumonia. If lobar pneumonia, we would expect focal crepitation, and it's usually cause crepitation. In the X-ray, we have discussed in the case. So in bronchiolitis, we will expect hyperinflation, flattening of the diaphragm, and also, like Dr. said, we will in severe cases there would be like some consolidation changes, or we can see right upper lobe changes, consolidation in the upper lobe because of the secretion is more. As we can see, as we know, the diameter of the right bronchus is bigger, so all the secretion will go downwards to the right lung more. So that's why it can have right upper lobe changes. For the pneumonia, we can look for consolidation, very high lung haziness, loss of heart border, like that. So that's all for the difference.
Hello. Okay. So for my name is Muhammad Shami. So for Archer blood gas, this is what one of that we are gonna test for this patient. So these are the normal range for Archer blood gas. So the pH need to be 735 to 7.45. I'm sorry, typo there. Okay. And the partial pressure of arterial oxygen should be 80 to 100, and for carbon dioxide is almost half of it, 35 to 45, and for bicarb should be 22 to 26. For arterial blood gas, so we can check for usually arterial blood gas is used for check for respiratory or metabolic acidosis or alkalosis, but it can also help in assessing respiratory failure to identify either the patient has respiratory failure type 1 or type 2. So to do so, we are focusing on more focusing on two parameters. Farah next, which is the PaO2.
So Jaime, it is very important to add the base excess.
Pardon?
The base excess.
Oh, the base excess.
Yeah, it is very important because it's a number will guide you. Do you need to intervene or not? Sometimes the bicarb can compensating respiratory issue like that. So it is very important to add it, please. Okay, continue.
Okay. So next. So for identifying respiratory failure, as I mentioned, there is type 1 and type 2. For type 1, there is generally just hypoxia. And for type 2, there is also hypoxia with hypercapnia. So with the parameter as I mentioned is PaO2, is reduced. in type 1, and also for type 2, there will be PaO2 will be reduced along with increase in partial pressure of carbon dioxide. So so for the type 1, it's usually due to gas exchange failure, and type 2 is ventilatory or muscular failure. So, ada slide tak ada. So, okay. Okay. So this is example. The example. So for patient A, if you are checking for a pH, we can look for the pH. We can check for the acidosis or alkalosis. So this patient is in normal range. So we could say is compensated, but for to check for respiratory failure per se, we are going to check for carbon dioxide and also oxygen. So the oxygen show hypoxia, and also, however, the carbon dioxide is not increased. So we can say the patient has a type 1 respiratory failure. Okay. Okay. For patient B, so you can see the pH is actually acidic, lower. So patient may have acidosis. So, but for according to if we are checking for respiratory failure, we can see that since the pH is low, so we can say it's uncompensated uncompensated. So for check for respiratory failure, so we check at the PaCO. The patient has PA partial pressure of oxygen of below the slightly below below the normal range, reduce PaO2, and also he has hypercapnia. So the patient might have type 2 respiratory failure. So we can also comment on the acid base. So the patient has uncompensated acidosis of the respiratory acidosis. So next, okay, done.
Okay, so next is guideline for hospital admission in viral bronchiolitis. So we can actually divide it into whether it is treated by home management or hospital management which needs admission. So who can answer? Maybe we can ask Farah Idris. Sorry, Farah Idris is in my team. So maybe we can ask apa ya? Izati, would you like to try?
So for age less than 3 months old, so it needs hospital management.
Okay.
Okay. Toxic looking, hospital management.
Go on.
For chest recession, both.
Okay, go on. It's okay, I will share the answer later.
For central cyanosis, hospital management. For wheezing, both.
Okay, next.
Crepitation, both.
Next.
So for feeding, if not tolerate, then hospital management. For apnea, hospital management. For oxygen saturation, if low, then need hospital management.
Okay.
For high risk group, then hospital management.
Okay, thank you. So these are the question. So you get it right, most of the question. So for example, if the patient is less than 3 months old, so it needs a hospital management. And then for toxic looking, of course, hospital management. If it's just recession, then we need to consider clinically whether it is mild, moderate, or severe. So if it's mild, then just home management is enough. However, if it's moderate or severe, then we need hospital management. For central cyanosis, as mentioned, by evidence of bluish discoloration of the gum or the tongue, so it needs hospital management. And then for wheezing and crepitation, it depends on our clinical evaluation. And then for feeding, of course, hospital management. For oxygen saturation, our aim is actually to be more than 95%. Hence, if it's less than 93, then we need hospital management for the patient. And the high risk groups, such as premature infants, child with chronic lung disease, or congenital heart disease, or neuromuscular weakness, or immunodeficiency, or malnourished, then it needs a hospital management for us to manage it well. And next, for quizzes. So what are the organisms that can cause bronchiolitis and which is the commonest? Adeline, would you like to try? I think it's already been answered.
RSV virus.
Okay, that's good, the commonest. How about other organisms?
Mycoplasma. Pneumonia.
Fishes.
Okay, so what could be the complications of bronchiolitis?
Respiratory failure. Is it?
That we can actually do.
Hello.
Zati.
Okay, what are the preventions that we can take, you know, to prevent bronchiolitis? It's okay, I can share the answer. So as you mentioned just now, RSV is the most common. However, there are other viruses that can contribute to it, such as human metapneumovirus, parainfluenza virus, influenza virus, adenovirus, rhinovirus, even coronavirus. And for bacteria, it could be Mycoplasma pneumoniae. So regarding the complications of bronchiolitis, so as you mentioned, respiratory failure can actually be one of the complications which might require intubation, and then apnea as well as so they can actually have a poor feeding that leads to dehydration. And then the prevention for bronchiolitis, there are two actually. The first is immunization with influenza vaccine. As we know, influenza is one of the virus that can cause bronchiolitis. And next is a specific RSV monoclonal antibody that we can actually give to prevent bronchiolitis, which we call as palivizumab. Okay, that's all from me. So I invite my friend Farah Idris to explain more regarding the X-ray, chest X-ray.
Okay, so as mentioned before, that one of the investigation needed to diagnose bronchiolitis is chest X-ray, and we can see from this chest X-ray that there is a hyperinflated lungs. For findings in bronchiolitis for chest X-ray, what we can find is hyperinflated lung, as mentioned before, described by the flattening of the diaphragm and also increase in the AP diameter. Aside from that, in bronchiolitis also we can find peribronchial thickening. And one to distinguish between bronchiolitis and pneumonia is lack of focal lung consolidative changes. However, as mentioned before, that consolidation can also be found in bronchiolitis in severe cases. And other thing for bronchiolitis is that they can have epileptic changes due to the alveoli collapsing. Okay, next. Then this is the finding for pneumonia. As we can see, there is consolidation on the left lower zone and also increase in very high left units. Okay, next. Lastly is foreign body. I know it's less likely in the patient, but we can, for foreign body, the chest X-ray will show a total opacity or homogeneous opacity of the object in the airway tract, anywhere along the airway tract. That's all the chest X-ray.
That's all for Oski from us.
Thank you. Well done. I will just write some points. You must revise it. one of you can write it to the group, so not be missed. Number one, importance of communication. I know that you are two colleagues getting the history, but sometimes we miss the importance of communication for the patient coming to us. He is in a weak situation. He needs some smiling, some soft words, some soon become better. And as you know, in Islam, even al-kalima tayyiba sadaqah. So it is better to sit somewhere. So it is very important, okay, for communication to introduce yourself, your name, what is the name of you, what is the name of your kids, like that, okay? I know that we are making just mock situation. As I told you, we are dividing pediatric to less than 3 neonate, which is the first month, and then the first 3 months is one category, and the 3 months to 3 years have also its own specificity, and after that, preschool and school. I send you to the group COVID-19 new regulation to both of you. I need to put it in slide so they can see it now until I finish my points which I need. So we must be updated from the regulation because this is an epidemic affecting now how many millions until now? Nearly 40 millions. So it is a very big number, and it's still it is working. So sometimes the regulation are changing between time and then, so must be updated. Okay. You must ask yourself what is the next system I must comment. Like at this situation, I have baby with respiratory distress and I can hear ronchi like that. So it may be asthma. To set asthma, what is the next system? In the exam, you have a patient with asthma. What is the important system you must comment on? The skin. You must look for the mechanism. It is allergy. So what is the one is most common is eczema or dermatitis. So I must comment even if negative. There is no eczematous changes, no apparent rhinitis or conjunctivitis, any other allergy. Okay, that's why you must ask yourself because it can give you the clue now for the ABI. You must revise it also. Asthma predictive index can be diagnosed by 3 attacks of wheezes with either 1 major or 2 minor. So it is very important to revise asthma predictive index. Okay. During your presentation, you told the mother it is easy. We'll just give him nebulization and the baby will be okay. Who agree and who disagree?
It depends on the situation, the severity.
So what type of nebulization?
It could be a normal saline or beta agonist.
Very good. So the normal saline is the gold standard for bronchiolitis. But the most important to take care about COVID-19, we are trying to shift from nebulization to metered dose inhaler. Why? In nebulization, it means the patient are making a fog in the whole area. Okay? So unless you are doing the PCR and 100% sure that the baby has not that, you can use it. Otherwise, it is better to go for MDI. And now we are able to use MDI even for younger age. Okay? Good, you make a gross and developmental you asked about, but try to categorize yourself. Gross motor, fine motor, and don't forget to put with fine motor the vision. I cannot catch a small thing until I have a good vision. So gross motor, fine motor, and vision, then hearing and like that, then the social one. Okay, so I try to even make your questions upon category. Respiratory distress, you're making a very nice slides, but you must know what is the respiratory distress score. Okay, you can revise it and just write respiratory distress score. You are going to use the same points, but to say the wind, it will be mild or moderate or severe. You just need to add decrease air entry, and if you have 2 or more, it is maybe considerable moderate like that. But if we come to cyanosis, central cyanosis, it must be severe and you must stand up and be ready to intervene. Okay. Thank you for commenting about Blavizumab, which is RSV passive immunization. It is a very expensive, but it is very good and have its own indication. You can go through it. Also, influenza virus not given for every age. There is some limitation. You must know about that. You must know about limitation of some vaccines. You can start to give it from which age, like 6 months or less. At the same age, many time I'm asking for cases of diarrhea. Is there any vaccine to prevent diarrhea?
Yes, rotavirus.
Rotavirus. When I can give rotavirus vaccine?
Rotavirus?
At which age? So if you read, you will find we will start from 6 weeks, and it is contraindicated to give it after 6 months. I need to give 2 doses, 1 month apart, but maximum at the age of 6 months. Why? It will tell you it may cause precipitate intersusceptions like that. So it is very important. Yes, we are using medicine, nothing without harm. It is the same. Anyone in his kitchen has a knife. It can cause harm. I must know, not to make harm. I will make it benefit for my life. I am driving a motorcycle. It is very important, but I must know. I must put like the head protecting my head, my phone, like that. So it is very important during prescribing medication from now, inshallah, until the long time you are practicing medicine. You must know the weapon which you are using may have some dangerous point. Try to consider it, please, during your prescribing. As I told you, some late onset sepsis in unit can be extended until 3 months. Thank you. You need to write all this and make reading effect so you can good benefit from your nice presentation. Okay. Who can present now the COVID latest regulation?
Hello.
Yes. This slide just shared yesterday by Dr. Ahmed Fazil, our respiratory consultant. This is the last updated, so I prefer to share it to you just to know, even for your safety at the time. Okay, who will comment? It is self-explanatory. So you need to know that we have now a suspected case or probable case or confirmed case or the BOS, okay? And everyone has its own criteria. And now we are insisting for the close contact what to do. What is the radiological criteria for COVID-19 if you are going to consider CT or other X-ray, okay? When I am going to admit and what is the criteria for discharge, okay? And admission criteria. Just try to go through it, please, okay? So we can go for the second case, which we have only 30 minutes. Okay, let us go for 15 minutes maximum. If it is 10, it will be better. Second group. Try to limit the presentation to 10, 10, 10, 10, please.
Okay, so I will. My name is Mohammad Shami. I will be the medical attendant. Medical attendees, and Shamila will be the patient's mother. Okay. Hello, Shamila, ready?
Yes.
Okay. So, Assalamualaikum and good morning. So, how are you feeling today?
Assalam. Hello, doctor. I'm okay.
Okay. I'm your medical student attending you for today. So, can I ask some things about your child illnesses?
Yeah, sure.
So, how is she feeling today?
Are you okay? Okay. She's okay. She said she's okay. Yeah.
Okay. So, can I know why is the reason you are coming to seek medical attention? Why the reason you're coming to hospital?
Because she had fever since like around 6 days ago.
Okay, good. So before that, she is okay. She is well.
Yeah, she was okay.
So other than fever, what the patient what does she have? Does she have runny nose or something? No?
She also has some coughing, and like the reason why I sent send her to the hospital was because I was getting worried because she started to vomit.
Oh, okay. So okay, Madam Shamila, can I know your child's name?
So her name is Shahira.
Okay. So how old is she?
She's 11 years old.
Okay, good. So regarding the fever, so I want to ask, is it very prominent? Do you check your temperature at home?
Yeah. We checked her temperature was 39 degrees Celsius.
Oh, I see. So is it suddenly 39 or suddenly she felt fever, or is it slowly, progressively she felt that something is wrong?
Yeah, she started complaining that she wasn't feeling so well in the morning. So like around in the afternoon she's already like feeling lethargic, so and she's feeling hot too. So I decided to check her temperature. So yeah, within one day.
I see. So the fever is continuous lah. Continuous, is it?
Yeah. What do you mean by continuous?
I mean, is it like intermittent fever, or is it like high all the time?
Oh, yeah, just continuous, I think.
So you mentioned the temperature was how much?
39 degrees.
Okay, I see. So is she shivering?
Yeah. She has some shivering, especially at night.
I see. So have you taken her to any clinic or any hospital before?
So on the same day of the fever, after knowing that her temperature was 39 at home, so I decided to bring her to a clinic, a private clinic, and yeah, So there, the
So
temperature was also 39.
okay. So did the doctor say anything or give any medication?
He gave her the syrup. I think it's
Okay.
paracetamol.
So is it working?
It's relieved temporarily, and then after
Okay,
that,
I see.
it's still hot. Yeah, she's still hot.
So okay. So you mentioned about cough, is it?
Yeah.
Yeah.
But
So
the cough,
when does it start?
the cough is on the same day as the fever, but it's like very minimal lah, not so much.
So is there any sputum or
No,
any?
no, it's not productive. There's no
Okay.
kahak.
Okay, tak ada kahak.
Yeah.
Okay, and since there's also no blood using
No.
after coughing.
Mm-mm. No.
No. So tell me more about the cough. Is it how the cough actually sound like?
The cough, it really just sounds like a normal cough. Like there's no unusual sound to it, so just normal.
So there's no hoarseness during the cough. Excessive hoarseness.
No.
The sound like no, and there's no like high pitched sound between the cough like when inhaling. No?
Oh, no. Just a normal and very minimal, just very occasional. Hello? Doctor?
Hello?
Okay.
Can you hear me?
Yeah.
Okay. So is there, you mentioned about vomiting just now.
Yeah.
So can you explain more about the vomiting?
So the vomiting was around the third day of the fever.
Okay.
So around one day too, she vomited around 3 times.
Oh, I see. So what actually she vomit out? Is it fluid? Is it fruit?
It's mostly fluid. It's just
Fluid.
watery. Yeah.
Oh, so it's no food. You cannot see no food, and there's totally no blood. Is it?
No blood.
Okay, great. So cumulatively, you think how much that she actually vomits out?
You mean the volume? Oh, so around maybe around two small cups. 2 cups, yeah.
Oh, I see. So does she like vomit randomly, or does she like there's specific time there where she vomit? Like after meal, before meal, or in the morning?
No specific time. Sometimes after meal, sometimes before.
Okay, good. So is there any other symptoms that you want to tell me?
So like when she vomited and everything, she can't really get herself to eat anything that much on the day. Yeah, so she had no appetite, not so much. Okay. So for the she also complained of some like ache, like sengal-sengal, like around the joints and also around like the arms. She complained of like aching sensation.
Okay, I see. So since she's been vomiting, so I want to ask either she is about her bowel. Is it okay? She complain of any pain, abdominal pain or something? No.
Yeah. Like on the same day of, I forgot to tell you, on the same day of the vomiting, she also had some loose stool. And before that, she did complain of some abdominal pain.
So how many can you describe the stool? Did she show you? How
I
was
was
the stool?
there. It's just I mean, it's not watery. It's not a watery stool, but I think it's a normal stool, like semi-solid. But it's not watery lah.
Oh. Oh, I see. So you were there when she was defecating. Okay. So how many times did she experience this loose stool?
Around three times per day.
Okay. How does it last? How many days?
It was around the day of the vomiting and also the next day.
I see. So so you came to this hospital because after she vomit out a lot of.
Yeah, and also I noticed that
So,
she was getting like more lethargic. I mean, looks more tired. So that's why I bring her to the ED.
So I want to ask, in your area, is there any fogging activity recently?
Yes. Actually, around this past weekend, there was fogging because one of my neighbors had a dengue infection.
I see. So so is she like usually going outside during dawn or after dark? Before dark?
Yeah, because I pick her up from school and usually she arrives home around 6 plus PM.
And also, does she complain of any rash, or do you notice any rash at her body?
Now that you mention it, it looks like there's some, but I think it only appeared today because yesterday.
This appeared.
Yeah. Maybe you can check.
Let me check. Yeah. So is there any COVID patient contact or history to endemic area? You went to travel to endemic area, no?
No. We have always been home.
Okay. Is there any rodent infestation in home, or is she have done any water-related activity or any recreational activity outdoors?
No. There was no recent water activity. We didn't go anywhere because of COVID. We're worried. Yeah.
Okay. Shahida, do you like gardening, or you have any interact with soil? No. Okay, good.
No.
So, did she complain of any night sweats, loss of appetite, or any contact with sick patient or TB patient?
No.
No.
Not that I know.
So, in the family, is there any similar symptoms occurs? Within the family, no.
No.
So, did she complain is similar symptom happening around her friends?
No.
So,
just her.
Okay. So, usually, will she eating from home cooked meal, or she went outside?
Yeah, home cooked meal. We don't really buy food outside. I'm a housewife.
Oh, okay, I see. So along the course of the illness, is there any loss of consciousness or seizures?
No.
Any fleeting episode? No. So is she been drowsy?
No.
So other than vomiting and abdominal pain, is there any shortness of breath, or distended abdomen?
No.
No. Is there any bleeding that you can see or bruising?
No. Except for today's rash, no other.
I see. So, is there any other medical condition that you want to tell me?
No, she's well. She's active and well.
She's never been admitted before, right?
No.
No. Okay. Is she on any prescription or any supplement or any kind of traditional medicine?
No.
So, is there any allergy to drug or to any food?
No food or drug allergy.
So, how many siblings she has?
She's only one. She's a single child.
So, her father is still here.
Yeah.
It's okay. So so how is the father? What is his name and
He's a doctor.
what she do?
Yeah, he's a doctor. I'm a
He's a
husband.
doctor. Oh, I'm pretty sure she will be taking care properly at home.
Yeah.
So is anyone at home is smoking or is she smoking?
No. My husband does not smoke.
Okay. I'm okay. So I can about your family finances can you guys support daily living?
Yeah. So
Your
far, there's not much problems in our family.
I see. So I want to ask a little bit about her birth history. So you have to recall quite back.
Okay.
So how is she delivered at what month? What week?
She's delivered at 37th week in HTAA, but through C-section because she was quite a big baby.
Why?
Yeah.
So is there any complication?
No, there was no complication after delivery, and during my pregnancy, there was also nothing much.
Is there any issue after delivery?
She had jaundice for like 1 or 2 days, but yeah, that's all. But didn't go into hospital or anything.
I see. So did you breastfeed her?
Yeah. I breastfed her for 6 months, and then afterwards it's formula.
Okay, I see. So do you like when the first she eat food, semi-solid food or any type of food?
Around I really can't remember. It was a long time ago, but around yeah, I can't remember. Sorry.
So currently, so currently, is she a picky eater?
No, she eats anything that I cook. I'm a good cook.
Okay, I see. So for along her lifetime, is there any abnormal development like she doesn't stop a little bit late or walking a little bit late? No.
No, she
No?
was.
Okay. So how about her social life? Is it good? School? At home?
School, you mean?
At school and home.
At home she's okay. She has her hobbies, and at school she has a few close friends.
I see. So is she? How about her academics? Is it okay?
She recently got first place in class.
Oh, that's great.
Yeah.
So did you vaccinate him? Her? I'm sorry.
Yes, always.
According to schedule.
Yes.
Assuming that your husband.
My husband is a doctor. Yeah.
Okay. Okay, thank you. So can I examine your child?
Yes, go ahead.
Okay. So doctor, I will directly present the PE finding that I would like to manifest. Okay. So she should be alert and conscious as per history and not in pain. So she was not tachypneic or tachycardic. Good nutrition test and should be well hydrated as there's no sign of shock. So okay, should be I expect to be rashes noted, which is if it's tally to the okay, there was rashes noted at the left upper limb, multiple pinpoint size with central palate and erythematous background. So the vital sign was normal. The temperature is 37 now, and the blood pressure and heart rate, the respiratory rate is all normal. So her developmental milestone is appropriate. She can walk, run, climb. She can okay. So for systemic examination for cardiovascular, there are dual rhythm, no murmur, the heart apex speed is not displaced, and there is a clear air entry bilaterally with no crepitation and not dull on percussion and equivocal tactile and vocal pharyngitis. So abdomen is distended and non-tender. for neurological, he has a good muscle tone, power, and reflexes. And there's no other neurological deficit. So my provisional diagnosis is this patient would have dengue on third day or on sixth day of illness with with warning sign, which is vomiting, abdominal pain, and also not in shock. So for this patient, I would like to do few investigation. So I will divide my investigation into blood and also imaging. So for blood investigation is we should do full blood count. So I'm expecting for leukocytosis with differential. I'm expecting for white blood cell count differential to be low in leukopenia, lymphocytopenia. Okay. And I will check for the hematocrit level. So I would like to have an initial marking for hematocrit level and look for the trend. And also I would like to see the platelet count. So but most importantly for blood investigation, I would like to do rapid combo test, the MD rapid combo test, in which we check for non-specific one antigen and also antibody. So then I would like also to do imaging. I would like to check for chest X-ray. So just to out any respiratory illnesses since the patient complain of cough. Such as pneumonia. Okay. Okay.
Okay, finished already?
Yes.
Okay, so I will ask you just rapid questions. What test for dengue you are going to consider?
Pardon?
The investigation, the test for dengue.
I would like to check for rapid combo test, which is the non-specific one, and also antibody.
If you don't have combo test.
Pardon?
If you don't have combo tests, what you will request?
I would like to do blood investigation, which is
No. I mean, what is combo test?
Zero.
What is combo test?
What is
combo test?
Combo test consists of two tests, which is non-specific one antigen, and also IgM and IgG.
Okay, so
antibody.
When you can use NS1 alone or NS or IgG IgM.
So there is you can. I'm sorry, I'm not really understand. You can do both.
It is based on the symptom. So whether this patient come in with fever less than 5 days or more than 5 days.
Okay, so thank you. That's why this is another important notice. We have some communicable disease in Malaysia, like any country has its own microbiome and infections and like that. Okay, you don't have any excuse not to be fully detailed about that cases. If we touch dengue or other common cases like thalassemia, like that, G6PD, no one will be supporting you. Because whenever go to right, go to left, you will find some patients like that. So please, take care. Do you know that even you have one dengue patient who died because the care of dengue fever, even if it is severe, can be done if started early, you can save life. If one patient die because of dengue, you will called to be for investigation all over the country, not even the state. It is not something simple because we have our own protocol, everything is clear. Okay, so every detail for that is very important. When I can ask NS1 because sometimes we have lack of resources, like nowadays after COVID-19. So I know if it is just in the first 2 or 3 or 4 days, it is enough for me to ask for, as your colleague said, in S1 may be enough. After 5th day, I can ask for IgG, IgM, like that, okay? So this is the most important. What is the types of dengue fever? You said it may be simple dengue, it may be dengue with warning sign, or it may be complicated dengue, yes, or severe dengue. What is the warning sign?
The warning sign is there is abdominal pain, intense abdominal pain, vomiting, persistent, bleeding, mucosal bleeding, lethargy or restlessness, hepatomegaly, and also hematocrit level, duration hematocrit level.
What else?
Fluid accumulation like ascites or
This one is it considered warning sign or severe sign? Okay, so all of you must know the warning sign from 1 to 7 or 1 to 8, like tac, 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 tac. No, it is not one by one. It is all. Am I clear?
Okay.
So we know how to diagnose, how to see the warning sign, what is the criteria for admission is very important. Okay, of dengue fever. What is the management of dengue?
So basically, the management for dengue is fluid therapy. So we are according to clinical and investigation of the patient. So we can classify that this patient falls under classical dengue with warning sign. So what we're gonna give this patient is that we must commence IV fluid around 5 to 7 kilo 5 to 7 mil per kilo body weight. So in 1 to 2 hours. Then if the patient does not show any, if the patient show improvement, then we can taper down the IV fluid into 3 to 5 mil per kg per hour for 2 hours, for longer, for 2 to 4 hours. Then afterward, we tapered more into 2 to 3 mil per kg per hour for 4 hours, and we should monitor for the hematocrit. And also, it's important since we are adding IV fluid, so it's important for us to do IO charting, input-output charting.
Yeah. So that is why I just you are said correct, but I must say it is number one is monitoring, close monitoring of the patient. Is not allowed to just admit dengue fever and put him in the ward and forget him. So we need frequent assessment, and the monitoring. And you must be clear, this patient need to be seen every hour and doing a vital sign, because maybe the normal for any staff nurse, she is doing a vital sign every 4 hours. If you didn't specify to her to do vital sign every 30 minutes or 1 hour, she will not do. So close monitoring, okay, close observation, and judicious fluid resuscitation. It is not open for everyone like this. So you must put input output chart at the top. Maybe still the patient not vomiting a lot. Do you know that the complication with hyperhydration sometimes more than hypodehydration? So we need the patient. That's why blood pressure will guide me, the pulse volume will guide me, the general condition of the patient will guide me. It is not roughly to put and goodbye, see you tomorrow. Very, very dangerous. Okay. So if you start any IV fluid with dengue, you must take care about the input output, as you said in the last surviving sentence you said. Okay, it is very important. The other thing, when did you suspect the complication can occur? At which stage?
During critical phase.
Which
around day 3 to day 6.
Which is the
critical phase.
Defervescent phase. Start now even to no temperature, he is improving. That's why take care. This is our responsibility of medicine, to go a deep, to be a more professional, to know a more details. That's why you are giving the job for humankind. And if we did it good, it will be like Allah said, وَمَنْ أَحْيَاهَا فَكَأَنَّمَا أَحْيَا النَّاسَ جَمِيعًا. If you help him to be life, and the meaning of life here is not to survive, no, to be in the best quality of life. Then Allah will reward you as if you help 7 billion patients, and Allah can give without limitation for anyone. So our intention to give the best, to be professional. You need to revise dengue again from A to Z, especially if we come to severe dengue with hemorrhage or with shock. How can we, and what is the criteria to transfer the baby to high dependency or ICU? It is very important. Two things very important for you, because I think the time is now going to finish. Number one, for the differential diagnosis will be, I know that it is not your business.
The differential would
number
be
one,
for this patient is
number one, don't tell me all differential diagnosis.
Okay. For current situation, maybe COVID.
Yes. Why? I know that we must rule out COVID. Do you know why?
Because it's still new and we don't really have a proper cure.
No, not at all. Some COVID
contact tracing?
No. Some COVID patient will react positive with dengue, and they are COVID. There is cross reactivity between COVID and dengue, which is something you need to pull your hair. So take care. Some cases of COVID-19 may react as a dengue positive. So many cases diagnosed as dengue and dengue positive and became in critical situation. I think we saw this scenario a lot, and admitted to ICU, okay, because the doctor is very sure is dengue positive, IgG, IgM, and S1, everything is positive, and the patient is shocked. So admit him directly to an ICU when they just collect the COVID test, found him positive. Okay. Another thing, other complication of dengue, other than we said it can be shock or hemorrhage or vomiting or other warning sign. Do you know any other complication of dengue?
Severe organ involvement such as myocarditis.
Very good. So any viremia sometimes. That's why we saw also, which your colleague may speak it about differential diagnosis, fever with vomiting. We saw some cases is clear cut meningitis. You have positive Kernicks and positive Kerstinsky and neck stiffness and blah 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 blah, and at the end it appears to be. We have one child, 13 years old, come with clear meningitis, but when we did COVID, when we did for him this dengue, it came positive, and it is known then any virus can go to the brain and cause meningoencephalitis. Okay. So that's why I am telling you the diseases which are endemic in our area, we must be very, very, very careful. We must read every detail because you will saw every word in a scenario with some patients. If you miss it, you can miss the patient and you can blame yourself. Okay? Please, fever is a very wide differential diagnosis. It needs from us about 2 hours to speak about it. We can just start for the differential diagnosis by your colleagues.
For the first differential diagnosis, apart from what we discussed earlier, Dr. mentioned COVID-19. As we know, like we see the symptom of COVID-19 earlier, so it can also have fever, vomiting, diarrhea. But in this patient, there is no history of contact or travel to COVID-19 and the mid area, high spot area. The second differential diagnosis could be leptospirosis. As you know, like the presentation is almost similar with the dengue. They can have fever, rash, myalgia, abdominal pain, diarrhea, and vomiting. However, there is no history to suggest any water recreation activity or jungle trekking or infestation of rodent at home.
What other clinical signs you need to ask for lepto?
Jaundice.
Wills disease.
Sorry, jaundice, okay, or transaminitis. What else?
Cough pain.
Yeah, cough pain. What else?
Congenital vasofacial.
Very important. So if you find this triad, don't omit the diagnosis of leptospirosis, conjunctivitis, transaminitis, and cough pain. Okay, of course, if you have a history of rat exposure, recreational activity, water, like that, it will, okay. What else? Other differential diagnosis.
Other differential could be food poisoning, since she has a history of loose stool as well as vomiting. However, points against it would be no history of outside food or any similar symptoms within the family.
Okay, food poisoning is very important. You must read at least one small paper in even Essential Nelson, because food poisoning is one of the forgotten disease. In spite most of us are eating external foods. Okay, so you must know how can we differentiate between different types of, and put this, and I need answer for all the point which I am giving to you, please, in the group. You can make one group for all of us together, so we can. Are you group 1 or 2?
Group 2.
Who is my group? Is it you are under which?
We're under Doctor.
Okay, so no, I think it is not, but we'll try to sort it with me through your leader, so I will not be confused between the groups. Okay, this is number 1. It is very important to know what are you speaking about, the differential diagnosis of
Leptospirosis, food poisoning.
Food poisoning, yeah, food poisoning. You must know the table. Okay, when the patient will get the symptom, when will start to vomiting, is it so early? Within the first 2 hours, up to 6 hours, up to 38 hours? What can be the organism? What can be the suspicious? And even the importance of notification if you suspect food poisoning. What is the investigation? Because it's a decision, it will be affect the other. So you must be clear about your diagnosis. You will inform the formal one, they may take decision to close some restaurant like that. It is, yes, it is for the benefit of the community, but we must be very sensitive and meticulous at that time. Okay. Other differential diagnosis.
Acute gastroenteritis.
Okay, so if we come to gastroenteritis, which is one of the common presentation and one of the common cause of mortality in pediatrics. What is the type of gastroenteritis?
Type of gastroenteritis, whether it is infectious or not.
Okay. What can be infection?
Infection can be like watery diarrhea, for example, in
No,
vibrio.
the causative organism.
Viral or bacteria.
Viral or bacteria.
Or parasites.
Oh yeah, or parasites.
Okay. What else can be divide the gastroenteritis? You are now in the 5th year. You must be able to detect different. It can be enteral or parenteral. What is the difference between enteral and parenteral gastroenteritis?
So parental is usually hematogenous spread. So the patient might have other infection prior to the gastroenteritis.
Yeah, that is to mean that the patient already have a systemic disease which is presented by gastroenteritis, but the enteritis only, it is a problem with the gastroenteritis only. This our case is parenteral diarrhea or parenteral enteritis because it is dengue and presented by that. What is other common infection which can be presented by diarrhea and looks like gastroenteritis in children? Very famous, more too.
UTI.
UTI, excellent. What else?
Pneumonia.
Otitis media.
Otitis media. So don't forget some like otitis media, some dengue fever, some even pneumonia. If it is a lower basal pneumonia, okay, it will cause irritation of the intestine and cause also parenteral diarrhea. Okay, so make your mind ready for diagnosing of the patient. Okay, other differential diagnosis. What about common diseases here? We said lepto, dengue, can be UTI, can be pneumonia, can be gastroenteritis, can be what other? Anyone knows about melioidosis?
Oh yes, it's endemic in Pahang. However, this patient no history of soil contact.
Not good. Number one. Number two.
Usually melioidosis more likely lung manifestation rather than other system.
Okay, what else? Something characteristic for melioidosis.
Usually melioidosis in immunocompromised patient.
But some children consider relatively immune compromised. Other important thing.
There's no sign of localized infection such as abscess.
Yes, this is a gold standard nizam. It's a very important. Because when we went to Tamarlo before, we found patient with 2 small abscesses. When we requested just melioidosis, it came positive. The issue with melioidosis, if you suspect, you must treat. Because even the test will take a longer time. And if you leave the patient for these few days without covering by strong antibiotic, the baby can die. So if you suspect by the history, don't say, usually, yes, I am 100% agree, but it is not absolutely difference between to say usually it is a disease of immune compromised patients, like eldest patient, like diabetes mellitus. Yeah, this is common, but it is not absolute. If they told you this absolute disease to this age, like disease assigning for HIV. If you find some that it is not coming to the normal, if you find it, you must suspect it is HIV or AIDS. This is a big difference. Okay, so myelidosis, you must know a hint about that. What other differential diagnosis? What mosquito can do other than dengue?
Malaria.
Malaria, yes, and it is available in some area of the Malaysia also. Okay, any area with a rainy weather. Okay, what is the characteristic of fever of malaria? You must know. Other manifestation. Tell me, Sharifa.
The fever pattern for malaria is a relapsing fever.
What is the name? Who can help here?
Can be.
What is the name?
Quotidian.
Quotidian. Yeah.
So this is an important lesson for all of us. You must go through the shape of the fever. You have now inside the computer, the fever is recorded. According to the type of fever, you can suspect some diseases. Like this quotidian, it will occur in a regular manner at every few days. Like the other, if typhoid fever, you will find step ladder. If you go, that's very important. Okay. So temperature chart is very, very, very important. Not temperature alone. All vital signs, as I told you before, are vital. All vital signs are vital. Don't underestimate it and don't make use of it. So we have a long series, may stay until afternoon speaking of the differential diagnosis of fever, but you must come back and divide it to like inflammatory, can be autoimmune, like especially if it is fever for a considerable time, because many cases like juvenile chronic arthritis can be presented by fever if it is systemic, and then some rash, and then and after a long time you will find the joint coming to tell I am here. So it is very important to consider according to your basic signs. Can be inflammatory, can be malignancy, even malignancy can be presented by fever, as you know. Okay, so don't forget your basic. If you put basic science in your bag, you will be very, very clever. If you throw it like most of us doing sometimes, oh alhamdulillah, push out this book from my side, physiology, histology, anatomy, pathology. No, you are still in need of it to be updated, doctor. Okay. Now the remaining is the slides. I think slides can be shared to the group, and I will be one of you. Okay, because time now is progressing so rapidly. The remaining 5 minutes, I need to get update from your side. If you need to ask any questions or any suggestion for our meeting, you are welcome. Yes. Yes.
I don't understand what you said just now. I don't.
If you have any questions or suggestions.
So, doctor, for infant, do we do nasopharyngeal swab for COVID test?
We have to test RTK, which is blood for IgG, IgM, and we have the PCR will be done for nasopharyngeal or oropharyngeal. It is standardized. because we are getting and ask number one, is there a COVID virus or not? Number two, how much is the load? PCR means you are able to count the number of viruses. So if you come to a certain limit of time, like 10,000, like that, it may be considered a true infection. And we are not able to admit even a small baby unless he did COVID. But if he's asymptomatic and no relation, low risk, we can also, in this updated one, which I give you, we can use RTK. But if any sign can be suspicious of COVID like that, we must go for RTK, PCR, sorry. Okay. Mm-hmm. Everything is okay. Okay, so it is, who is the leader of this group? Is it Hariza, Adeline? I don't know, or both of you?
The one who contacted you was Adeline.
Adeline. Who
Yeah.
is
Yeah.
who is Hariza? Is it
She's from another group. Hazira, is it?
Hazira.
Hazira, yes.
She's from group 1.
Okay, group 1, and you are group 2. Adeline
Group
is
2.
So Adeline, you need to send me the name of the attendance and write beside everyone what is the rule he shared today.
Okay.
Okay. If you are able to send me what is this, the copy of the history with you of the patient and the slides after trying to sort it upon our comments. If you are able to send it to me today afternoon, is it okay?
Sure, doctor.
Okay. Okay. Nice to meet you, and hoping inshallah you start your clinical life even through internet. We are doing our best inshallah until you are able to come to the world. But I need you to start to practice examination. This is my last advice to you today. Even practice in your own child, in your brother or sister, even in your colleague. To have a good flow is very important. Okay, and remember that clinical examination have a many station. Okay? The first station, it is introduction. And the introduction will include, number one, introduce yourself. Number two, take permission from the family. Okay. Number three, positioning the child and exposure. Okay. And lastly is the hand washing or hand rub. This is a routine. Introduce, hand rub, take permission, hand rub, positioning, and exposure. And then you will come to the next station, which is observation. And remember to be a good observer. Observe, observe, observe. Okay? So observation is very important. To observe, number one, the patient, especially in pediatric, you must be able to see he is dysmorphic or not. Okay? What about his growth and the development? And you must say, I'm going to plot him in centile chart. You must be able to say has any acute condition or not. Is there anything which is connected to the child, like saturation probe, like any other vital signs? You must be able to pick it. And lastly, what is around the patient? You may find around the patient like nebulization machine, like a bottle of urine collection, like wheelchair. Everyone will give you a guide. Sometimes you need to take care even from the mother or the father. Thinking before, we have in the 5th year, we have one patient with cafe oil spots. And really the mother has a lot of neurofibromatosis. And you just ask the mother, please, you can let your hand clear in front of the students. No one comment about the mother. Because it's still evolving signs for the child. Yes, the only spot, but the mother.
Keteruk sangat internet hari ni.
Yes, yes.
Sorry, Doctor.
The baby has cafe on the spots, but the mother has neurofibromatosis. Okay, so I will come to the conclusion it is neurofibromatosis. Okay, that's why number 2 is the observation, and observe the child, observe the situation, even observe the family. Okay, after that you must start peripheral from the hands, front and back, and then come to the vital signs, and then come to the head, eyes, neck, mouth, neck, everything, and come to the organ itself, and try to go also systematize by inspection, palpation, auscultation, percussion, and you must be able to do all that and come to a conclusion. Otherwise, if you are randomized, you are did a simple job. Oh, I check the volume of the pulse, but I forget to check the rhythm. I forget to like that. I need to come back. It is not good and wasting the time. Okay? Am I clear? So please
Yes, Doctor.
do your best to start this year strong, more professional. Hoping inshallah we see you in the best groups. Bismillah. Thank you.
Thank you very much, Doctor.
Waiting for Adeline
Thank you,
Dahlan.
Doctor. Yes, I.
Come, drop it to me by night, inshallah. Thank you.
All right. Thank you, Doctor.
Thank you, Doctor.
Thank you, Doctor.
Doctor.